Good evening. Welcome to the webinar, Culture Hour at Home, a program created to support Black African American patients and caregivers who live with Crohn's disease and ulcerative colitis. I am Donna Etheridge, a volunteer for the Crohn's and Colitis Foundation, and I will serve as the moderator for the program this evening. I am also a patient and serve on the D&I Patient and Caregiver Advisory Committee for the Crohn's and Colitis Foundation. I was diagnosed with Crohn's 22 years ago after my colon ruptured. My journey has been full of ups and downs, but I am still very optimistic about one day being free of IBD. Now, the Crohn's and Colitis Foundation is committed to ensuring that all patients receive the latest IBD information and resources. This program is one of many events we will host for patients and caregivers this year. We have a wonderful agenda prepared for you all, which includes a presentation on IBD symptoms outside of the gut. Inflammatory bowel disease can cause a variety of symptoms, both in the gut and outside the gut. When the disease affects other parts of the body, this is known as an extraintestinal manifestations or complications. Between 25 and 40% of IBD patients experience extraintestinal manifestations, commonly in the joints, the eyes, skin, bones, kidneys, and the liver. During this webinar, we will address how IBD manifests itself outside of the gut, specifically in Black African American patients. After the presentation, we will have a question and answer session in which you will have an opportunity to ask questions to our presenter by typing them in the questions box. Now, please note, all attendees will remain muted throughout the webinar. Before we begin, I would like to thank our program supporters, Eli Lilly, Genentech, and Takeda. Thank you for supporting this program and our priority for serving all communities. Now, I am very excited to introduce our presenter for this evening, Dr. Florence Demalola Odufolo. Dr. Odufolo is a passionate provider and clinical researcher in gastroenterology and inflammatory bowel disease, including Crohn's disease, ulcerative colitis, indeterminate colitis, and microscopic colitis. Her research and clinical interests are in disparities research in IBD, women's health in IBD, and pregnancy in IBD. She is also interested in the manifestations and outcomes of IBD in communities of color. Dr. Odufolu has published many groundbreaking research articles and reviews assessing IBD care in pregnancy and in ethnic underserved communities. Dr. Odufolo serves on the editorial board of Inflammatory Bowel Disease Journal. In addition to her contributions to research, Dr. Odufolo's focus is to provide excellent evidence-based care for all of her patients. I apologize. Dr. Odufolo currently serves as the Assistant Professor of Medicine at Keck Medical Center at the University of Southern California. Thank you for joining us this evening, Dr. Odufolo. You have the floor.
Wow, thank you for that wonderful introduction. It's really a pleasure to be here today. My name is Dr. Odufolu, and I'm an IBD specialist at Keck Medical Center of USC. Thank you for this opportunity to present today, and thank you for everyone in attendance for your time and your interest in this space. So today I've been tasked with discussing extraintestinal manifestations of inflammatory bowel diseases, and in particular with an emphasis on how that can impact skin of color. So thank you for sharing your time with me this evening. So here are my financial disclosures, none of which are relevant to the lecture today. So we'll briefly talk about just IBD in general, and then we'll jump into the manifestations outside of the gut. So, inflammatory bowel disease encompasses ulcerative colitis and Crohn's disease. And briefly, ulcerative colitis is a chronic, relapsing, and remitting inflammation limited to the colon. You can see that this image here, this cartoon image in the center of the slide, shows an image of the GI tract, including the small intestine and the colon. What's highlighted here in red is the lower portion of the colon, which includes the rectum and the sigmoid colon. In ulcerative colitis, typically the first place where ulcerative colitis presents and the most severe area of inflammation is in the rectum. Inflammation is generally limited to the lower colon or the left side, but in a subset of patients, the inflammation can extend to the entire colon, and that term is called pancolitis. And so this this red area would actually just go and wrap all the way around here. This image here on the left is a picture from a colonoscopy. This shows a colon with very severe inflammation from ulcerative colitis. That's demonstrated by all of this redness here, or termed erythema. There's also some ulcerations down here, and this is pretty friable. Friable means that bleeds easily and the tissue is a little bit weakened. In this image here on the right, are some pathology slides, which are biopsies from an inflamed colon. I'm not by any means a pathologist or really trying to take the place of pathologist, but what this emphasizes, when we take biopsies of the colon, we're looking for, under the microscope, are we seeing evidence of inflammation? And here in these pictures here, we're seeing a lot of inflammation by all of those purple cells that are in the colon here. That indicates that there's inflammation going on. And next, we'll move to the discussion of Crohn's disease. And I've included a lot of images here of the colon and the perianal region. So Crohn's disease is also a chronic and relapsing and remitting inflammation of the GI tract. You can have inflammation in the colon as well as the small intestine and the upper GI tract, including the stomach, esophagus, and then the mouth. And here are, in this slide, just show some pictures of things you can find in Crohn's disease. So you can see pseudopolyps or fake polyps in the colon, which generally indicate evidence of prior inflammation or scarring. Here's another image from the colon showing ulceration here, and again, redness and friability. Here at the top is perianal Crohn's disease. So there is a fistula forming, where a fistula is an abnormal tract from one area to another, and there's a tract forming from the colon to the skin, and there's likely an abscess in here or a collection of infection. And then in these slides here is a stricture or a narrowing in the colon, and in this patient, the patient had a surgery before, and there's narrowing where the surgery was. And this just shows a endoscopist trying to stretch out that narrowing so the patient doesn't have symptoms of obstruction or difficulty passing food. And so we'll move on to our discussion of IBD. What really drives me and what has really shaped my career is when I was in medical school, inflammatory bowel disease was taught and was thought to be inflammation of the GI tract, primarily in patients who are of Western European ancestry. And I found that when I became a medical resident and in practice, that's not in fact what I saw. I saw that inflammatory bowel disease affects patients of all different races and ethnicities. And I'm sure everyone here attending this lecture knows that very well. This slide was taken from a journal article that looked at the estimates of inflammatory bowel disease in different racial and ethnic groups. And you can see here that across all different age ranges, inflammatory bowel disease is prevalent. And What's interesting is that over time, we've seen that these rates are rising in all populations, but in particular, it's rising in patients who are non-white, so Hispanic patients, Black patients, as well as patients who are from Asian ethnicities. And so now we'll shift our discussion to extraintestinal manifestations of inflammatory bowel diseases. What extraintestinal manifestations mean is that patients have Crohn's disease or ulcerative colitis, but they've also got inflammation in different areas outside of the GI tract. And so this cartoon image kind of shows um, areas where we can see common extraintestinal manifestations. And just starting from the top, from the bottom, you can have inflammations that are ocular or involving the eye. And you can see here, this image here shows a red hot eye. And this patient in particular has uveitis. Uveitis is one of the more common ocular manifestations of inflammatory bowel disease, but you can also have scleritis or episcleritis. You can also have musculoskeletal involvement, which means musculoskeletal is involving the bones in the joints. What we typically see is arthritis, arthritis related to another autoimmune disease, or an arthritis just related to having inflammation somewhere else in the body. Another form of arthritis is sacroiliitis, or inflammation in the sacrum, which is lower and located in the lower spine. Those patients will have patients kind of right above the bottom, and pain with sitting, standing for prolonged periods of times, and with walking. And then there's ankylosing spondylitis, which is inflammation of the spine, and that causes pain within the back, and then long-term pain and stiffness in the back. You can also have biliary or inflammation of the bile ducts that manifests as primary slow-stirring cholangitis. We'll talk about that later. With IBD, we also see higher rates of blood clots. Blood clots are often termed DVT when they're in the limbs, so in the legs or in the arms, or pulmonary embolism. That's when a blood clot travels to the lung. We typically see blood clots happen in patients with IBD when there's uncontrolled inflammation. And so it's very important to get control of that inflammation early on. There's also aphthous ulcerations or canker sores, which you can see here in this upper right image. And then there's also extraintestinal manifestations that occur on the skin. That's where we'll spend a bulk of this lecture series, because that's where I find the most of the disparities in extraintestinal manifestations with inflammatory bowel disease. So why are extraintestinal manifestations important? So as Donna mentioned earlier, extraintestinal manifestations are very common. We see that it's been reported to up to 47% of patients with inflammatory bowel disease will have some sort of inflammation outside of their GI tract. Typically, we see that happens after the diagnosis of IBD. So about 74% of patients, about three-fourths of patients will have their extraintestinal manifestations become prevalent when they know that they have a Crohn's disease or an ulcerative colitis. But about a quarter of patients will have those manifestations before their diagnosis, or even before the symptoms of Crohn's disease or ulcerative colitis manifest. And so now let's shift our talk to the skin findings that we see in IBD. And I'll preface that I am not a dermatologist, and I don't pretend to be one. And this lecture series is not meant to take the place of seeing your dermatologist, but oftentimes when I'm seeing patients for their regular checkups, or when they're in a flare, they'll report to me their GI symptoms, but then they'll also report to me their skin findings. And we see skin extraintestinal manifestations more commonly because there's this phenomenon called the gut-skin axis. And we think that's because the GI tract, as well as the skin, have this relationship where there's immunologic pathways that work together. And so oftentimes when there is active inflammation of the gut, we can see that the immune pathway then triggers the immune pathway in the skin, and we often see those skin findings show up. And so this is a cartoon image that shows how the skin and the gut are related. So the bottom portion of this cartoon image is supposed to be representative of the GI tract. And you can see that this looks like a healthy membrane protecting the GI tract. We've got our food and then the microbiome or the bacteria that live in our gut just freely kind of exposed. And then this top portion of the cartoon image is supposed to represent the skin. And so we can see here that this is supposed to be a hair follicle, and you can see that there's an immune cells here that live in the skin. However, when there is dysbiosis or when there's a break in this healthy barrier and these microbes get exposed to the immune system, they travel within the blood vessels, and it can activate the immune cells within the skin and lead to inflammations. And so before we get started talking about the specific disease states within the skin, this image here is representative of inflammatory bowel disease in the world. And so, like I mentioned, inflammatory bowel disease was thought to be a disease of Western Europeans or of industrialized countries. And so the highest rates of inflammatory bowel disease are here highlighted in orange. And so here in the United States and in Western Europe and in Australia, there is a well-known prevalence of inflammatory bowel disease. However, here in Africa and in some parts of Southern Asia, there is an emergence of inflammatory bowel disease. So the researchers in the studies noted that we're seeing more and more patients in these regions that typically it was not well described having inflammatory bowel diseases. And in yellow, so in Mexico, South America, and in Asia, there is an accelerated incidence that is happening. So we're seeing higher, very fast rates of inflammatory bowel disease um, uh, showing up in these different countries. And so I'd like to take this image and then put it on top of this image of the skin of color map. And so very similar to our previous slide, we can see that lighter skin tones are in North America and in Western Europe, and the darker skin tones are seen along the equator, and it gets a little bit lighter as you move north and south from the equator. And you can see these, the areas that had the emergence of inflammatory bowel disease were more common in Africa and in South America. And so before we get started on the skin conditions, I'd like to talk about the Fitzpatrick scale. This is a scale that tries to define different skin tones based on the amount of melanin. And so again, we know that inflammatory bowel disease is in North America and in Western Europe, and it was typically well described in those populations, as well as the extraintestinal manifestations were well described in those populations. However, in the areas that have more melanin, so type 4, type 5, and type 6 on the Fitzpatrick scale, we're seeing an emergence of patients that have more melanin, and therefore, when we're having more of these patients diagnosed with inflammatory bowel diseases, that comes along with more extraintestinal manifestations. And so the first condition we'll talk about is erythema nodosum. And most of the images here are from my own clinical practice and from a recent paper that I published last year in the Journal of Inflammatory Bowel Diseases. This paper was meant to bridge the knowledge gap of extra skin manifestations of inflammatory bowel diseases in skin of color. I found that not only in inflammatory bowel diseases, but a lot of dermatologic conditions. The descriptions in skin tones with more melanin or darker skin tones are lacking. And so what I hope to do is bridge that gap and provide pictures for patients, pictures for providers to better recognize how these skin manifestations show up in different skin tones. My ultimate goal is to publish an atlas with every Fitzpatrick scale represented across all cutaneous extraintestinal manifestations, but I've realized over time that this is a challenge just because um, it's a lot of conditions, and I have to have a lot of different patients of different skin tones. So it's a work in progress. So erythema nodosum is a skin condition that has been typically characterized as a red and tender nodule in the skin. And this typically occurs when there's active inflammation. So in patients who are having a flare or when they're newly diagnosed, patients will notice, well, some patients will notice that they have this tender red area. The most common place is actually on the leg, on the shin. And so you can see here, I've got one of my patients here, this is on the shin. One of my other patients, it actually showed up on the hand. And then this is a patient with more melanin, and you can see that the presentation is a lot different. So in patients that have more melanin, instead of being red, the presentation can be more duskier red to violaceous or a violet color. And sometimes it doesn't have really any color at all. Um, but what's very prevalent across all skin tones is that it will be tendered to the touch. What's important to note in skin of color is that when this resolves, sometimes as it heals, you can have hypopigmentation or lightening of that area, or hyperpigmentation or darkening of that area. That becomes a major concern for patients of color because scarring can be very disfiguring. It can cause really a lot of vulnerability or self-consciousness. So important to recognize. So the next skin condition is called pyoderma gangrenosum. This comes in about 4 different flavors. This is typically, again, noted on the shin or on the lower legs. However, you can have pustular pyoderma where there's a lot of pus forming, and this can occur during periods of inflammation. It can also occur when there is not inflammation. And you can see here, this is typically how it was described here on lighter skin tones, where it will be purple and have a central pustular area. But you can see on these 3 images, these are all patients, and then this is a colleague's patients. It didn't have that classic purple finding, except in this patient here, you can see there's a little bit of purple in the periphery, but in darker skin tones, instead of being purple, it's more dusky. It's also just more hyperpigmented instead of purple. And then you can see here, all of these patients with resolution have scarring with hyperpigmentation as this resolves. Before we move on to another condition, there's something called peristomal pyoderma gangrenosum. This is a phenomenon that happens in patients who have an ostomy, so it can be an ileostomy or a colostomy. And what happens is in that around the ostomy or the stoma, you can have, again, this pustulous area with surrounding hyperpigmentation occur. I don't have this finding. I didn't have a patient with a darker skin tone and of a type 6 skin tone in my clinical practice, but this is a patient with type 3 skin tone who has resolving peristomal pyoderma, and you can see it involves the ostomy as well as the surrounding skin, and we've got pustules forming here. This is a very severe case, and you can see that when this occurs, it's not only incredibly painful and disfiguring, it makes putting an ostomy bag on this around the ostomy very challenging. And so what patients who have this finding do is they often don't put a bag on. And so that means feculent contents will then continue to irritate this area and cause a superinfection. So I bring this up because this is often an area that your gastroenterologist will typically not examine during the office visit because there's typically an ostomy bag on top of it to collect the stool. And so what I try to do is to empower patients to check their ostomy area every time they're changing their bag. And if you're starting to note the early signs like this patient has here, take a picture, send it to your doctor, and then also be prepared to show your doctor in the office visit. So that means bring an extra ostomy bag to your office visit so you can take it off and put it back on, because it's very important to highlight this finding early on and to get you to a dermatologist or to a surgeon pretty quickly so that we can do local treatment, or we can try to do an intralesional or inject medication into these ulcered areas to help them heal quicker before they become incredibly disfiguring. The next skin finding we have is Sweet syndrome. This is a very rare dermatosis. It's called a neutrophilic dermatosis. And what happens is it causes very tender or painful red plaques, often around the neck area or in the trunk. On biopsy, so when we look at this under the microscope, we'll see a lot of inflammatory cells called neutrophils, but it's in the absence of an actual lesion or inflammation of the blood vessels in that area. The criteria for this are indicated here. And you can see here, instead of having that redness that's typically described in skin of color, the redness is more subtle, it's dusky, or it doesn't have any pigment at all. As you can see here in this patient from our skin of color dermatology clinic, this patient, this image was provided, and there's no color here. There's just painful little nodules here that the dermatologist recognized very quickly as a Sweet syndrome. And so now we'll shift our discussion to anti-tumor necrosis factor, or TNF psoriasis. Psoriasis is another autoimmune condition that can occur with inflammatory bowel disease or without inflammatory bowel disease. But I wanted to talk about anti-TNF psoriasis because this is a rare finding that is associated with the medication we use to treat or we can use to treat inflammatory bowel disease. So this occurs when a patient is on an anti-TNF medication. Those medications include infliximab, adalimumab, golimumab, or certolizumab. All of those are approved in ulcerative colitis and or Crohn's disease. And this is a patient from my clinical practice that I included. She doesn't have a dark skin tone, but I wanted to include these images because of the sheer severity of this condition. It typically does not present this severe at all. Anti-TNF psoriasis will present like regular psoriasis does. So in white skin, this will typically present with, it's described as a silver or gray plaque on the extensor surfaces, so on the elbow or the knees. There is often some surrounding redness as well, depending on the severity. However, with anti-TNF psoriasis, you can have that silver plaque, but it doesn't have to be typically limited to the extensor surfaces. It can be on the inner portion of the elbow. It can be on the knees. In this patient, it's actually on her trunk and abdomen. It's also on her ear here and caused a little bit of disfigurement. It's also extended into the scalp, and so I wasn't really able to capture how bad it was, like within her hair. But as you can imagine, this is incredibly painful and also very itchy. And so what happens is when this presents, patients will be scratching, and that can also lead to a super infection on top of that. In skin of color, the plaques are not typically silvery until they become more severe and inflamed. They will typically be more violaceous or a violet purple color. They can be gray or dark brown. Once, and then a special skin of color consideration is that once these lesions heal over, there's generally a hyperpigmentation, so a darkening of the skin even after the inflammation has resolved. Risk factors for developing anti-TNF psoriasis. Not you have to be on an anti-TNF medication, but other risk factors include smoking and tobacco. So that's why we recommend for all of our patients to try and abstain from tobacco products. Number one, just for overall health and wellness, but it can make this this condition more prominent. I'll move over to a discussion of herpes zoster or shingles. Shingles is not an extraintestinal manifestation per se, but it is a common finding in inflammatory bowel disease. Some reports show that patients with inflammatory bowel disease across all age groups have a higher rate of shingles compared to patients without inflammatory bowel disease. Your risk can also be higher with certain medications we use to treat inflammatory bowel disease, specifically JAK inhibitors like tofacitinib or upadacitinib. And shingles, I included this cartoon image up here of shingles, which shows that shingles typically presents in a single dermatome on only one side of the body. So in these two patients here, the inflammation is limited to the left side of the face, and it's actually limited in the region we call V1 on this image and V2 on this image. And the rest of the skin, for patient privacy, I didn't include the entire face, but the rest of the skin on the face and on the body is normal. In this patient here, you can see it's just in this one dermatome, and we think that it occurs in this one dermatome is because the shingles virus is a reactivated chickenpox virus, and it lives in the nerves in the spine. And when it becomes reactivated, it travels along one single nerve in the spine and will go to the skin. I've included an image of the shingles vaccine called Shingrix as a plug to encourage patients to get the shingles vaccine. So before the shingles virus presents, oftentimes it will present with severe pain. And even after these lesions heal and crust over, there's something called post-herpetic neuralgia, where patients will have long-term pain even when the skin looks normal. And the skin will generally heal without scarring or pigmentation. The Shingrix vaccine is approved for patients without any comorbid conditions above the age of 50, but it's also approved for patients who have an immunocompromised state. So patients with inflammatory bowel disease are encouraged to get this medication prior to starting a medication that suppresses the immune system. It's given as 2 doses, so on day 1 and then 6 months after that. The Shingrix vaccine is not an activated vaccine or a non-live vaccine, so this can be given even while you're on a biologic medication. And the next slide we'll talk about is skin cancer. So skin cancer includes non-melanoma skin cancer or melanoma skin cancer. Skin cancer is not an extraintestinal manifestation per se, but it is seen at higher rates in patients with inflammatory bowel disease compared to patients without inflammatory bowel disease. So the incidence rate ratio is about 1.5. And it's thought to be related to sun exposure, as well as associated with some medications that we use to treat inflammatory bowel disease, particularly 6-mercaptopurine or azathioprine. And so these images here are melanomas, and I can't see this one because my face is covering it, but in these two, these are kind of classic because they're dark and they're abnormal in their shape. So this looks kind of like a little fish here instead of like a typical mole that is generally round and uniform. Even though this is kind of round, it's more oblong and it has this area of redness on one area, so that's concerning. And then I've included here melanomas in skin of color. And so I feel like a lot of people feel that skin cancer is not prevalent in patients of color, um, but that's not in fact true. It may, I'm not sure about the rates compared to other skin tones, but there absolutely is a risk for skin cancer in skin of color, and these are images here. So this is incredibly abnormally shaped, so not round or uniform, and it also has this area of central hypopigmentation here as well as here. Here's another area, another patient with skin cancer, but this is in a non-skin exposed area. In patients of color, there's a there's a skin cancer called acral lentiginous melanoma that typically occurs underneath the feet, underneath on the palms of the hands, or underneath the nail beds. I wasn't Bob Marley's doctor, but I suspect that's actually what type of skin cancer Bob Marley had, because he had a skin cancer underneath one of his toenails, and that's actually what he passed away from. And so to prevent skin cancer, I recommend for all patients with inflammatory bowel disease, especially for patients on biologic medications or patients on immunomodulator therapies, the primary prevention is to use sunscreen. And so again, when I was growing up, my parents thought, oh, we're Black, we don't need we don't need sunscreen because we don't burn. But we burn less, absolutely. However, our skin can burn and our skin can get skin cancer. I feel like growing up, I didn't have a lot of options for sunscreen that didn't leave that white cast. And so that made wearing sunscreen very annoying. But several there are several sunscreens on the market that are emerging that do not leave that white cast on melanated skin. And so I just included an image I found on Google of one sunscreen called Black Girl Sunscreen that does not leave a white cast, but also has a very high SPF offering skin protection. The next secondary prevention for skin cancer is annual skin cancer screening with a dermatologist. So I recommend this for patients with inflammatory bowel disease, so on a biologic medication or an immunomodulator. They should establish with a dermatologist and have a skin cancer screening at least annually. And that's when a dermatologist will look at your skin and look for abnormal lesions and take biopsies if needed. And so that's my recommendation. for skin cancer. And then lastly, the last extraintestinal manifestation is PSC. Um, it stands for primary sclerosing cholangitis. This occurs more commonly in patients with inflammatory bowel disease, but I wanted to include this slide because there's what's thought to be a separate disease entity, PSC, UC plus PSC. So in patients with ulcerative colitis who have PSC, they are at a very, very high risk for colon cancer. This occurs in less than 10% of patients with ulcerative colitis, but when we do have that finding, we take this incredibly seriously because at least 50% of patients will develop colon cancer if they have this disease entity. And so what we do is if you have this diagnosis of UC and PSC, you undergo colon cancer screening every single year. And we do that because we want to find abnormal lesions that can turn into a colon cancer. And I've included these images here on the right. So this is a patient who has ulcerative colitis as well as PSC. And you can see the colon actually looks fairly normal, but there's this very subtle finding here. And we use a special dye called methylene blue that when we spray it, healthy normal tissue shows up blue and abnormal tissue won't pick up the dye and will remain pink or white. And you can see when we spray this area, this abnormal area doesn't pick up the dye. And this is either a skin cancer or a dysplastic lesion or a lesion that will become skin cancer. Typically, when we found patients who had these dysplastic lesions, they automatically went to remove their entire colon. But um, we have new interventions now available through a lot of gastroenterologists where we use high definition and we can do specific techniques to remove the entire lesion but save the colon. And so I hope you take away from this slide to please be adherent with your colon cancer screening checks because we can find these lesions early and prevent um, morbidity. So morbidity meaning being sick, having to require surgery, and sometimes we can prevent death from a cancer progressing. And so I'd like to thank you for your time today and for really your interest in learning about manifestations outside of the GI tract. That was kind of a lot, but and a little technical. But I know everyone here is really kind of interested in their overall health and getting more information. So I welcome any questions about anything I discussed today or even other conditions related to Crohn's or ulcerative colitis.
Thank you so much, Dr. Odufolu. That was so much insightful information. Again, I have Crohn's disease and I was recently diagnosed with PSC.
Oh,
So,
wow.
as a patient, I've learned so much more about extraintestinal manifestations. And I'm sure others on the joining the webinar feel the same way. Again, that was absolutely amazing. It was in terms that we could understand. And I'm sure that we are so much better for it. Knowledge is power. So, again, thank you so much.
Oh, of course. Thank you for having me.
My pleasure, our pleasure. Well, at this time, we're going to move to the question and answer portion of the program. If you have a question, please type it in the Q&A box. And we kindly ask that you keep your questions general so that everyone can benefit from the discussion. And we're going to try to answer as many questions as we can with the time that we have left. So I am going to, oh, I see quite a few here. We have 6 questions already. So I'll read these for you, Dr. Odufolo, and we can get it started. Okay. So the first question, this person has been diagnosed with UC 13 years ago and have recently been diagnosed with MS. Are they connected? And how is autoimmune treatment prioritized or balanced?
Okay, so thank you for that question. So the question is, um, the patient has UC as well as a new diagnosis of multiple sclerosis.
Yes.
Multiple sclerosis is a autoimmune condition of the brain and can lead to a lot of morbidity, actually. And so the question is, are they connected? Um, we don't have a good answer specifically for UC and MS, but we do know that autoimmune conditions kind of run together sometimes.
Mhm.
And particularly with UC and MS, I do believe that they do share some pathway in the inflammatory cascade. We know that because we have two medications available that treat ulcerative colitis as well as multiple sclerosis. So that is ozanimod and natalizumab is another medication that treats ulcerative colitis as well as MS. And so the second part of that question is, how is the autoimmune treatment prioritized or balanced? And what I think this question is asking is, do we try and aggressively treat one or the other? Um, and so sometimes we do, but if for me, I have a couple of patients who meet that same criteria, and I actually try to treat both of them because, as we know, having ulcerative colitis symptoms untreated is terrible, and having MS treatments untreated is also terrible. And so, what I try to do is work with the neurologist because the neurologist generally manages MS. I try to find a treatment that can treat both so that you don't have to be on more than one medication. If I can't get away with one medication to treat both, then we're talking about putting you on two different immunosuppressant medications. And that's sometimes okay as long as we're closely monitored. But if you're having side effects from having too much immunosuppression, we might try to pause that and treat the more aggressive disease first. So if the UC is aggressive, you're having bloody diarrhea, pain, hospitalized from that, we might table the MS treatment first until we can get control of your UC and then add on another treatment until that's better controlled.
Wow, thank you so much. I'm sure that helped. The next question we have from Elizabeth. She wants to know if she can get a Tdap vaccine while using NTVO.
Yes, you can. That's not a live vaccination. So, um, really, any vaccination that's not live, you can get. So, uh, some examples of live vaccine, I believe, are like yellow yellow fever is a vaccine that you'd have to take when like going to I'm Nigerian, so like when going to Africa, you have to get that vaccine, and that's a vaccine you can't get while on a biologic medication, but Tdap is fine. So just like the yearly flu vaccine is an
Mhm.
inactivated vaccine, that is fine to take while on Entyvio or any biologic.
Okay, thank you. The next question comes from an anonymous attendee, and they say, sorry if you've already discussed this, but they have IBD and is having issues with, I guess that's Mila, Milla, or Mila, and acne. Is that something attributed to IBD? And if so, what recommendation do you have to address it? Thank you.
So, great question. I did not touch on this. So, milia and acne. I'm not too familiar with milia per se, but acne can be associated with inflammatory bowel disease, but more commonly, acne is associated with the medications, some of the medications we use to treat inflammatory bowel disease. So, acne is associated with JAK inhibitors, or so JAK inhibitors are tofacitinib and upadacitinib. I'm not sure if I'm allowed to use the trade names in this space, but I'll say so. That's Xeljanz and Rinvoq, and then another medication that everyone is probably very familiar with. Acne is associated with steroid use, so with prednisone.
Mm.
Um, so I've actually heard a dermatologist term IBD acne as Jacne because it's associated with JAK inhibitors. It's
Oh, wow.
pretty common and hard to treat. It generally has a nodule. It's called nodular cystic acne. So you'll have like they'll be like rubbery and nodular, and sometimes pretty painful. And then sometimes there's like cysts with pus in the acne.
Wow.
Um, to address this, I recommend working with a dermatologist. Your gastroenterologist can generally prescribe like a topical antibiotic to try and help lessen the acne. But when it becomes more severe and nodular cystic, the dermatologist will generally have a couple different approaches. And generally, they'll do that all at once to try and get control of this. If it's related to prednisone use, my goal is to get you off prednisone ASAP with the maintenance medication without side effects.
Okay, thank you. Our next question is, um, she says, I've been dealing with skin issues, so you put a light on it all, and she's appreciative. Finding doctors to take you serious is the issue. Uh-oh, a little thing skipped here. I'm so sorry. Let's go back up. Okay. Finding doctors to take it seriously is the issue. This person has Crohn's disease. However, it gave her stage 28 colorectal. I'm sorry, is that
Okay.
stage 2B? 2B, sorry, colorectal cancer. So she wants your perspective on that.
Yeah, so I am so sorry that this happened to you. Um, and as we mentioned kind of in the last bit of the lecture, colon cancer is more prevalent in patients with both Crohn's and ulcerative colitis. Unfortunately, patients with skin of color, immigrants, minority patients, it's sometimes hard to be taken seriously because of the misconception that inflammatory bowel disease doesn't really affect patients very commonly that are minorities. We know that's not the truth at all.
Mhm.
And so attending education sessions to empower you, I think, is really a great place to start. Um, and my recommendation is if you feel like your doctor isn't taking you seriously, you can tell them that. If it feels like a little uncomfortable to do that, find a new doctor that listens to you.
Mhm.
And then tell that doctor, the next doctor that you see, just say, I saw this doctor, but I felt like my concerns of X, Y, and Z were not taken seriously. So that's at the forefront of their mind.
Okay.
I always like to, for me, I always like to, when I see patients, before we end our encounter, I like to ask, is there anything else that you want to
Mhm.
address? Or is there anything else that I can do for you? Um, Sometimes if it's a lot of stuff we're dealing with, I'll say, what's the top three things that
Mhm.
I can address? And we'll have to table it for the next visit. So empowering yourself, be prepared when you
Mhm.
get to clinic. So have your questions. Sometimes a list is really nice too. And if you're still not being heard, find somebody that will listen.
Thank you. That's definitely a situation where patient advocacy is so important. So I'm glad you emphasized that. Okay, our next question. Can you speak about treatments that can be used once the extraintestinal manifestations occur?
Yeah, so this is a multifaceted question. There are a lot of treatments that we can use when these extraintestinal manifestations occur. It kind of depends on which one. So if there's so for example, erythema nodosum, typically really anything to get the inflammation under control. So be it a TNF medication or a JAK inhibitor or an integrin like Entyvio, getting you under control quickly is kind of the best thing to make those things better. But some extraintestinal manifestations have a lot of good data specifically. So for like pyoderma, anti-TNF medications actually have the best data. We didn't talk about hidradenitis, but that's um, an inflammation of the glands. So like we'll see that in the armpits, we'll see that in the groin. That works best with anti-TNF medications. So
Okay.
it really just depends on which one we're dealing with. But there is data to help steer you one way or the other.
Okay. Thank you. The next question, and this is a good one. Does IBD, I'm sorry, all of them are good, but this is one that I know a lot of women are curious about. Does IBD affect fertility?
So great question. I really like women's health and fertility just as a woman, and I think fertility and pregnancy planning is important. Inflammatory bowel disease can affect fertility. We know that patients with chronic inflammatory conditions have a reduced fertility compared to the patients who are just healthy without any medical comorbidities. But
Mhm.
once you're under control um, with a medication or with however you and your provider achieve remission, fertility is generally not that severely impacted. A lot of people, and however, one scenario where fertility can be affected is when there is inflammation in the colon that's in the pelvis, and that
Mm,
requires surgery. And so, surgery in the pelvis, so particularly removing the rectum, that can sometimes cause scarring in the pelvis that can impact fertility. And so, when you are young and of childbearing age, we generally try to do pelvic sparing surgeries until you're ready to until you're ready to have your children. So if you need your colon removed, we can put an ostomy there temporarily until you're done having children, and then we can take it down.
mhm,
Um, there's some surgical interventions that reduce scarring in the pelvis, so that's something you want to talk to your surgeon about. Um, there's been some studies looking at patients with inflammatory bowel disease undergoing assisted reproductive treatments, so egg freezing, IVF, IUI. Having inflammatory bowel disease does not impact that. And so patients can undergo assisted reproductive therapies without concern. The medications for IUI, IVF do not make IBD worse, do not lessen um, your IBD medication's effectiveness. So all of that is fine. One caveat I'll include is that some medications are contraindicated or avoided in pregnancy. So that's the JAK inhibitors. So upadacitinib, tofacitinib, as well as methotrexate, and as well as the S1P inhibitors, so ozanimod and etrasimod are avoided in pregnancy. One medication, mesalamine, I'm sorry, sulfasalazine can affect sperm production in men. And so
mhm,
not particularly just production, but the movement of the sperm. that's called oligospermia. And so that can be impacted as well. But once you come off of those medications, sperm quality is restored. Once you come off the JAK inhibitors or the S1P inhibitors, your ability to become pregnant and stay pregnant and healthy is not
Mhm.
affected.
Okay. Thank you so much for that great information. We have so many questions that were asked, but unfortunately, we're running up against time. But we're definitely going to provide a solution for you all who did not have an opportunity to get your questions answered live during the webinar today. So, as we close for the evening, I would like to thank you again, Dr. Odufola, for providing the insightful presentation and all of the information that you've shared with us for the Black African American community as it relates to extraintestinal manifestations. The Crohn's and Colitis Foundation is so grateful to partner with a physician like you to help bring this information to the forefront for us. So thank you again. We really do appreciate you.
Horace, thank you for having me.
Our pleasure, absolutely our pleasure. I would also like to thank our supporters again, Eli Lilly, Genetech, and Takeda. Last but certainly not least, thank each of you for joining us for the webinar tonight. We hope you gained some insightful information and additional information about Crohn's disease, ulcerative colitis, and those extraintestinal manifestations. Before you log out tonight, we ask that you complete the brief survey that we've placed in the chat box on the screen. The link and QR code will take you directly to the survey. Evaluations assist us in developing future programming. So thank you so much in advance for completing the surveys. We also encourage you to visit our website and learn more about our resources. We have a variety of resources such as Facebook support group for Black African American IBD community, and we'll also be starting a virtual Black African American women's regional support group that will be available to you all soon. We also have brochures and fact sheets that address several IBD topics. All of this information can be found on our website. Now, if your questions were not answered tonight, I encourage you to visit our website for more information. You can also contact our IBD Help Center, and that information is on the screen. Thank you again for joining our webinar, and we wish you a great evening.